Assalamu alaikum and welcome back to another episode of What's Up, Doc. I'm your host, Dr. Aalia Al-Barwani, and I'm a board-certified physician. My show, What's Up, Doc, is a production of Muslim Network TV, the only Muslim-focused network broadcasting in North America. You can watch all of our shows streaming on Roku TV, Apple TV, Fire TV, and Galaxy 19. And you can also catch us on our YouTube page at youtube.com/Muslim Network TV. We also have a website, and you can see our shows there at muslimnetwork.tv. Today we have a really exciting show, and we're going to be talking about all things menopause. Joining us in that discussion is Dr. Sameena Rahman. Dr. Rahman is a board-certified obstetrician and gynecologist. She was raised in North Carolina, where she attended Duke University for a bachelor's degree in biology and specialized in women's studies. She then went on to the University of North Carolina at Chapel Hill for her MD before moving up north for her residency in obstetrics and gynecology at the University of Massachusetts. Dr. Rahman is a specialist in menopause management and also specializes in chronic pelvic pain with particular interest in sexual dysfunction among Muslim women. She is a clinical assistant professor in the Department of OBGYN at Northwestern Feinberg School of Medicine and currently owns a private practice in downtown Chicago. Welcome, Dr. Rahman. It's such a pleasure to have you here today.
Hey, assalamu alaikum. I'm so happy and excited to be here. And I was so excited to learn about the network, and it's just so much good stuff going on.
Thank you. We're really excited because, especially, mashallah, with your credentials, you're definitely well-versed in today's topic as our expert for today's topic. And what a service to the Muslim community to be able to provide what you're providing to the women, not just in Chicago. You probably see people from across the country and maybe even internationally.
It's actually true. I have seen, I did a couple consults for some individuals in Pakistan in the last few months, actually. So it was interesting. That was they found me on, through the internet. And it was something that I really enjoyed doing because, again, there's not a lot of information about a lot of the stuff that I discuss. And a lot of the stuff is so taboo that people just, don't bring it out in the open. So. Exactly.
So I assume this was a virtual consult as opposed to them flying out from Pakistan.
Yeah. Nowadays there's so many virtual consults, but yeah.
That's good to know. So for anyone who has any issues, either related to what we're talking about today or sexual dysfunction or any of your specialty issues, they can reach you on your website, and we'll share that information throughout the show.
Absolutely. I would love to see anyone across the country or I actually still have my medical license in California, so I can technically still see those patients just through television.
Excellent. Very cool. So we have you on here today to talk about one of your specialties, which is menopause. And for a lot of people in different cultures, it is something that is dreaded. In Arabic, translation translates into like the age of depression. It's very, it's terrible. Just to show that this is, we've had a series of taboo subjects, and this is just another one of those things that we don't really talk about. And for a lot of women, they're either left feeling isolated or confused about their symptoms. So I'm really excited to talk about this today. And let's start by defining what menopause is, because there are some symptoms that can lead up and be confused as menopause. So let's start by defining menopause.
Yeah, menopause by definition is a period of time, is really the cessation of, ovulation when you've really ovulated your last egg. And so what happens is women, tend to, after 12 months of not menstruating, that pretty much defines your state of menopause. So your final menstrual period usually is 12 months before, and then the symptoms we'll discuss that come along with it. But that's by definition, what we talk about when we talk about menopause is the cessation of really the reproductive function defined by 12 months without menstruation in the midlife.
And I think that for a lot of my patients, when I explain it to them, that timing piece is also important, because some women that I see will believe that they're in menopause because they haven't seen their menses for 6 months or so. And then suddenly it'll come to them, or they'll have spotting, and then they'll get worried because they thought they were in menopause. So I love and I encourage that in that definition, we really wait for that year to be through without any bleeding.
Absolutely.
For us when a woman is in menopause, and that's really important for a lot of reasons. So thank you for that. So tell us, what is a typical age? Of course, there are exceptions to the rule where we see early menopause, but what is a typical age that we would see a woman or expect menopause to occur?
Yeah, average age of menopause is 51 and a half. And so, in general, we talk about there are factors that influence it. Obviously, women tend to go into menopause around the same age as their mother. Now, the reality is, a lot of mothers don't talk about their menopausal state. So, or have, I have some patients that were, say, oh, I remember when my mom was going nutty, like in her 40s or 50s. But, so I think that was when she hit menopause. So that's how my patients tell me that what they think their age might be. But, in general, I think that, many generations before us have not, but although women are now starting to talk more about it as we're trying to get more control over our health. But yeah, average age is 51 and a half, and some women go through it earlier. There definitely, I have a good percentage of women that, are in their mid 50s and beyond and still menstruating. So I think that, it's important to know that. And if you can know your family history, there are other factors that affect, menopause, which include, obesity, alcohol use, smoking. Some of those other things can affect when you go into menopause as well.
Exactly. And I really like the point that you made that we don't talk about it. And I think we need to get into the habit of talking about this because it has a lot of implications in our health, not just with menopause specifically, but in general, things that run in families. It's really important to be aware of that family history so that you can take care of your own health and then that of your children as well, and be proactive about it. So I like that point that you made there. Now, we've been talking about some of the symptoms that lead up to patients thinking that they may have menopause. Why don't we just actually start talking about what are those symptoms that
symptoms?
Besides going, what did you use, nutty or just
yeah. My mom was going nutty. Well, I think it's important to remember that, menopause is actually the cessation of one of our major reproductive hormones, which is estrogen, right? So when your body stops producing estrogen, any receptor in your body is affected by the lack of estrogen or the declining estrogen levels. So we can talk about that whole perimenopausal shift too. So, you have estrogen receptors in the brain, in the bones, in the vagina, in the bladder, like anywhere in the body you can think of, there's probably an estrogen receptor that is impacting. And so really menopause can affect women from head to toe, honestly. So I always talk about the first thing is obviously menstruation cessation. One thing to remember is you're born with all the eggs that you'll ever have for your whole lifetime. So when that final egg is released, that's why the age of menopause is only affected by certain factors, but genetics is the biggest one. But like I said, if you think about mental health, there's some changes that occur in that during menopause. The biggest symptoms that you always hear about, though, are the hot flashes and the night sweats, which are hot flashes that occur at night. And so one of the things, about 75% of women will experience it, and about 80% will have the hot flashes or night sweats for 2 years or less. And those are the most problematic of life. It's really like a flushing of the skin, feeling warm, and then the same thing happening at night where you feel like you want to take off your clothes because it's so hot. So, so it's a thermo dysregulation that happens that estrogen is involved in. Other things we talk about are the genital and vaginal changes. There's, it used to be referred to as vaginal terminology, and we call it the genitourinary syndrome of menopause, because it really isn't just about, the impacts of the vagina. Obviously, the skin in the vagina thins out, it dries up, the acidity, pH changes from acidic to basic, and so there's a lack of your lactobacillus in the normal flora in the vagina, and so you have those changes that's why there's more dryness and you don't produce as much discharge. There are women in menopause really suffer from a lot of urinary symptoms. The trigone of the bladder is, lined with the estrogen receptors. And so you have a tremendous amount of urinary symptoms that can involve recurrent urinary tract infections, urgency symptoms, increased urinary incontinence that happens. Your pelvic floor muscles are impacted. And so if you already, had vaginal deliveries and you were doing fine, for that period of time, when menopause hits, a lot of time you get more relaxation. That's when we see more of the cystoceles, the rectoceles, and other issues around your vaginal, your pelvic muscles, actually. And sexual pain is one of the big, components of genital urinary syndrome or menopause, and that has to do with the dryness. Not only the dryness, though, to be honest with you, the other hormone that declines in menopause, we have to remember your ovaries are also responsible for testosterone production. So when you have this dearth of testosterone in your system, and we have to remember that our vulva and the vestibule, which is the area between the inner labia minora and your hymeneal remnant, as well as your clitoris, the whole area needs testosterone to be healthy. And so a lot of women will then find the labia regress, and you have all these architectural changes in the vulva. And that actually results in sexual pain that we talked about. So that vestibulodynia that we talk about with pain upon initial insertion happens because of the hormonal changes of the lack of testosterone and estrogen. So that's kind of like the genital urinary syndrome or menopause, the urinary symptoms that develop. In perimenopause, leading into menopause, women develop a lot of what was brain fog, where you have almost like a verbal inability to remember things. And so, because, your hippocampus and your prefrontal cortex are lined, or also have estrogen receptors, what ends up happening is you have all these changes in your memory and cognition, and that can really impact women dramatically. Mood disorders are very common, which I think we're going to expand upon. But, and to be honest with you, it may not all be hormonal related. It's also related to sort of like what's happening to women in midlife. Many of us, are in like a sandwich generation where we're taking care of little kids as well as, our parents. So that's one thing that impacts us. Some of us are at the peak of our career. And so there's many things that affect women. And so when you get these menopausal symptoms that compound it, you actually end up, in, a worsening mental state. Upon later, but that's some of the other symptoms that are really bothersome. Insomnia, sometimes related to the night sweats, sometimes related to all the other factors we talked about, but the lack of sleep and lack of good sleep and sound sleep can impact women overall and affect their quality of life. Your skin changes. Obviously, there's more wrinkling. You don't have enough estrogen to get that good collagen in your system. So, people's vision change. You have your bone health changes, obviously. And when that happens, sorry.
You were not kidding when
your
you
bone
said
health change
it affects every part of the body.
I know, I can keep going. Breast tenderness, chest pain.
Oh, Dr. Rahman.
People get palpitations, weird chest, things. So, we see it all. And so, it can be attributed almost everything to menopause. So when a patient comes in and tells me all these symptoms, and she's like, do you think this is all menopause related? I'm like, absolutely. Absolutely it is, So, like I said, I can go on and on, hair thinning, acne, all this stuff. So, all stuff.
Wow, it sounds like definitely, when you described the hot, the nice sweat, and then the vaginal dryness, the brain fog, those are usually the more common symptoms that I see. Of course, I don't see nearly as many women in menopause as you do, or experiencing symptoms as you would. So my pool is going to be smaller, but all of these other symptoms, of course, it makes sense when I think about it in terms of the science behind it, but there is a plethora of symptoms, and it sounds like it's a struggle for a lot of women, especially when you bring up that this is something that is kind of out of their control to an extent. That you can seek help, and there are ways to manage, of course. And in addition, you're dealing with regular life stuff, right? And so this doesn't make sense. Thrown on top of it, just like when you mentioned the sandwich generation, where you've got kids and then you've got your elderly parents you're caring for. That already is a high stressful state for a lot of people.
High stress, yeah.
It does compound mental health issues, which you did briefly talk about. And I think that it's important for us to talk a little bit more about, because I do get that a lot. And I do notice that a lot of patients come in and they're just very irritable, or their husbands will bring them in and they'll be like, something's going on. Wife.
Fix my wife. Yeah. I'm going to divorce her. Yeah. This is what people say. And so, yeah, I mean, absolutely. And you know, the reality is some studies show that women that are menstruating at the same age as women who are not, you know, still have the same level of, you know, mental health issues. But we do see more diagnoses of depression. I think there's a lot more anxiety disorders that come up in the midlife. And I think that has to do with all these changes that women are experiencing. But of course, I mean, I can't emphasize this enough, but if you're not sleeping normally because of the hot flashes and, you know, your body's feeling all these weird changes, maybe you're having some weird heart palpitations, or you feel dizzy and you're like, what is this? Or maybe, you know, you just have some weird sort of chest pain that isn't like the typical stuff that you think about. There's all these different symptoms that you might have that all of a sudden, you know, make you think that, am I going crazy, or is this really happening to me? And I have patients tell me that all the time. Like, you know, I talked to my doctor and they just told me to go on an antidepressant, but I think there's more to it. And, you know, we always talk about the hormone impact, but also, you know, like we can't disregard the fact that women in the midlife are under a lot more stress than they were maybe when they're in their 20s. You know, people are getting sick in their life. Like we talked about the balancing act, you know, the peak of their careers, you know, all of these things are compounding them, and they maybe wake up in the middle of the night and they're thinking about all these things that they have to do, and the anxiety is building for them. So the anxiety, I think, is something that I see like much more commonly, as well as depression symptoms. You know, some women really get depressed at the idea that their reproductive years are over. You know, maybe they didn't have a chance to have a baby or weren't successful, and all of a sudden, you know, you tell them that, well, you don't have any eggs left, really. So it becomes very depressing for a number of women. So that depression, along with those hormonal changes, can, you know, really get exacerbated. You know, there is even a lot more bipolar that we're seeing in the midlife. And then on top of all of that, you know, just, you're right, the irritability and the angriness, and, you know, maybe, you know, the whole thing about, you know, everything going on in the world bothering every, you know, you're just carrying the weight of the world on you. And so I think all of those factors really start to impact women and how they feel about themselves and their mental status. And because there's so much taboo associated with, you know, depression, anxiety disorders, and all of this for women, especially, to be honest with you, in our cultures, right? Like in a lot of Muslim cultures, I know in Pakistan, India, like, you don't talk about it, right? And so, you know, therapy is not a thing that people do, you know, and because it's not, you know, accepted as a real form of, you know, treatment or whatever the case may be. And so if you're not going to seek help because it's too taboo to talk about it, then you're just building, you know, it's just penting up a lot of negative feelings, and you know, it can be really detrimental to women.
Suffering in silence when we really have so many treatment options. And we're going to get to it later in our episode, but definitely therapy. I talk about therapy all the time on my shows. And, we've had several episodes about that. So thank you for bringing that up. I love how thorough and in-depth we are going with this. We do need to take a quick break here. So we'll be back. You are watching What's Up, Doc, and stay tuned. We'll be back after this short break.
There are 16 million children struggling with hunger in America. That's 1 in 5 daughters, sons, neighbors, and classmates who don't know where their next meal is coming from. Yet billions of pounds of good food go to waste every year. It's time we do something about it. Feeding America is a nationwide network of food banks that helps provide meals to millions of kids and families in need. Visit feedingamerica.org to help them feed even more. Together, we can solve hunger. Together, we're feeding America.
When times get dark, we can't see the help that's all around us. Let 211 be your guiding light for help with food, healthcare, and other resources.
211, how can I help you?
Call 211 or visit 211.org. 211, Get connected, get help.
Right here, baby. Look. Uma.
Noah. Something more than a birthday is happening here. Once you can see it, you can help. The sooner you recognize the signs of autism, the sooner you can make a lifetime of difference for your child. Start by answering a few simple questions at screenforautism.org.
And welcome back to What's Up Doc. I'm your host, Dr. Al-Barwani, and today we are talking about all things menopause related. We are talking to Dr. Sameena Rahman, and before the break, we were talking about the plethora of symptoms that can be associated with menopause that a lot of women may not be aware is attributed to menopause. And so I love the level of detail that we went into to kind of encapsulate a number, and I'm sure you, like you said, you could have gone on. So that you probably just hit the tip of the iceberg. So if you're having symptoms that you're unsure of, I think the best thing is to kind of say, hey, go talk to your doctor and ask them if you're in the right age group. Which brings me to my next question, Dr. Rahman. I know that we talked about the average age and we talked about the typical age, but there are in some cases where there is early menopause, which is either induced or due to ovarian failure or other reasons. And I would like to spend a little bit of time, because I don't want definitely the take-home message to be that if you are not in this age group, there is no way you could be going through some type of menopause. So I do want to talk a little bit about the unusual case where it may happen at a younger age.
We oftentimes see patients who have had premature ovarian failure, or, basically defined when it's like 40 or younger. These women, for one reason.
And sorry to interrupt you, but to break that down, as you mentioned, menopause happens because the ovaries, not to say that they fail, but they've kind of done their job. And so right. For women where this is happening at a younger age, that's considered a failure of the ovaries because they're the job isn't done, but they've stopped working. Right?
They stopped working. And maybe it's genetically that, chromosomally, that's how many eggs they produced that's how many eggs they had when they were babies, and they were, that's all they had. It could be other factors involved. There are women that develop a wide variety of cancers that, either chemotherapy or radiation induces their menopause. And so a lot of times there are things that can be done, before they get that to, preserve ovarian, preserve eggs. But, the reality is some of them do end up in menopause. Or, we have patients that have surgical menopause, which is when the ovaries are both removed. So there are plenty of women that have hysterectomies, which is the removal of the uterus. But when you have both ovaries or oophorectomy removed, that can induce a surgical menopause. And many times the symptoms are sudden and intense. And so, there are usually certain medical conditions that, render that necessary, whether it's, cancer or other like prolonged conditions. And so a lot of women will have these either surgically or chemically induced menopause from the agents that they've taken. And again, the other category was the premature ovarian failure, which is oftentimes genetics or other factors involved.
Okay, thank you. So they would experience the same symptoms as what you
said.
Okay, similar.
Absolutely.
Okay. Mm-hmm. Now, as far as, symptoms are bothersome, but is this detrimental to one's health? Do women who go through menopause have to seek treatment? What are the repercussions long-term of no longer having the levels of estrogen and testosterone that they had in their younger age?
Mm-hmm. There are many, obviously. We talk about, there was we can talk about the Women's Health Initiative that was back in the 90s shortly, but basically, what we know about women, what we know about estrogen is that we think that there is a cardioprotective effect that, probably happens for women. And so heart disease is much more common in the postmenopausal state, which is still the #1 killer of women, right? Heart disease is still the #1 killer of women. So that is something that we look out for more. And these symptoms of sort of atypical chest pain and other things are more aggressively looked into and diagnosed. Obviously, in terms of other factors, when you have that lack of estrogen and testosterone, I think that's the biggest one we talk about, are things that can cause, that can lead to increased mortality, essentially. But, other factors are related to, I'm sorry, I just blanked out. What was the question?
I'll tell you that I know. There's a lot to cover.
I was like, wait, what was the question? Where was I going?
You're fine. There's also a lot to cover. But one that I usually will have to watch out for my patients and kind of counsel, even maybe earlier than menopause, is with respect to bone density and
osteoporosis and osteopenia. Mm-hmm.
Exactly.
And so, whereas, the osteoporosis, osteopenia, as you know, doesn't necessarily kill you, but the consequences of them can, right? The fall, that's why we worry about elderly women when they fall and when they're frail and they fall and they break their hips, which can then, have a downward spiral. But yeah, bone health, of course, is one big issue as well.
So definitely important to understand quality of life is certainly very important, but it's not just quality of life stuff. There are other things that also have to be addressed or should be addressed.
Absolutely.
Yeah. So do you usually recommend for patients going into menopause? I know that I do for pretty much all my patients, really, vitamin D in general, just because no matter what, everybody I check, unless they're taking a supplement, they have low vitamin D.
Yes,
so
absolutely.
One of those vitamins we should all be taking anyway.
Absolutely. Yes.
I don't know how thorough or how much more studies have come out with respect to COVID, but there was at the beginning some benefits found to be with vitamin D.
Vitamin D, yeah.
So I think it's one of those vitamins that you should always be taking anyway.
Absolutely. I do too. And, that's one of the things I always talk about are some of the supplements, like before even talking about actual treatments for symptoms, I'll talk to patients about supplements that might help in overall quality of life. Vitamin D, at least 5,000 units, as you probably know. And if they are really low, obviously we give them higher doses, up to 10,000. But vitamin D, I think, we think it might help your energy and be anti-inflammatory, and there might be other things in the works that we're seeing. Calcium is one of the supplements that I recommend, at least 1,200 milligrams a day.
Although sorry to interrupt you, Dr. Rahman, although we just had an episode recently where we had a discussion about the value of calcium because we had an episode of urinary stones and the doctor. No, you're fine.
No, I was going to say, I usually try to encourage people get it through food versus actually taking a supplement. So we talk about, and there are certain apps you can go into, say if I have this much yogurt and this much cheese, am I getting like the equivalent of what 1,200 would be? So I don't actually encourage too much in terms of supplementation, but just see if we can incorporate into our food, because we don't even know if we're taking the extra calcium, if we're really getting that absorption, right? So I think that, the food intake in your diet is what I usually try to push more than the actual supplements. And then I like to talk about also, your B vitamins. We know that they can also give a little more energy to people. Vitamin B12, vitamin B6, we know has sort of an anti-nausea effect, and maybe even, can help with sleep in some ways. Magnesium, citrate oxide, I usually recommend that as a supplement. Women in menopause often have bloating, and the weight gain we can talk about separately. I didn't even mention that in my earlier talk, but that's probably the #1 reason women come in menopausal weight gain. But, just keeping your bowels regular and reducing that bloating can be very beneficial to women. And then, just a variety of other ones, the riboflavin, which is another B vitamin, obviously, for people with joint issues, there's like costochondroitin and the coenzyme Q. Some people are using more often too. So I will review some of those lists of sort of vitamins and supplements that I think could benefit overall health, and I'm sure you do the same in your practice.
I love that. I do like to take a comprehensive approach to treatment with anything.
Absolutely.
So yeah, if we can either recommend supplements or dietary things, then I'm always for it. So that's the perfect segue to start talking about treatment, and let's start with like lifestyle stuff. So you mentioned some supplements. Let's talk a little bit about lifestyle and maybe even dietary as far as things to avoid soy and such, as far as addressing some of the symptoms that you mentioned.
Absolutely. I mean, that's one of the biggest things I talk about with my patients is sort of like improving your overall lifestyle. Number one, I always talk about sleep. Like, we do not emphasize the importance of good sleep enough. I mean, I think that, especially as physicians, we have living behind a sleep debt for so long that we don't even realize the impact it's had on us. But, 7 to 9 hours of good continuous sleep is always critical. And so I often tell patients to keep a sleep diary, what's been, causing or hindering their sleep, and sort of the insomnia around that, because we do find women, I mean, is it the hot flashes? Is it that you're getting up to pee 3 times a night? What is it that's causing, is it the stress of taking care of everyone in your world? What is it that's causing that sleep to get disturbed, and how can we adjust that? And, one of the big factors is really like your sleep hygiene, and what are your sleep habits? What are you doing at night to kind of improve your sleep overall? So I think that we can't say enough about good sleep. I mean, even when you're talking about metabolic function and weight gain, sleep is such an important factor in that. The second thing I always talk about is the importance of exercise. As we all know, we need to have some, good cardio, and, even like yoga, Pilates, low intensity exercise, and really weight bearing exercise is so important for our bones. But, also when you're dealing with all these mental changes, these changes in your mental status and your anxiety levels and the stress levels, nothing is better than those endorphins that you get for me, that's, I don't run to try to lose weight or whatever. I run because it clears my head and I feel better at the endorphin rush is really helping me. And so it lifts some of that stress that might be impeding your quality of life. So I always talk about finding some form of exercise that's going to improve your mental health, but also, if you're using it for weight management too. And then the other things are, just, trying to have a balanced diet. Some people really, push omega-3 and fish oils and all that stuff. But I think that, even incorporating, fish in your diet, some anti-inflammatories, vegetables, having a good balanced diet and drinking plenty of water, although it's always dangerous to drink it too close to sleep when you're in that menopausal state.
Good.
Because you're going to be up, and then your sleep is going to go.
You just said 7 to 9 hours of like continuous restful sleep, which is canceled by getting up to use the rest.
2 to 3 times, absolutely. So I think that, that's the big problem that we have with the whole drinking too much water too close to the evening. But, between the exercise and the sleep, as well as, a good healthy diet, those are kind of the first line things that I always talk about when we talk about lifestyle changes. And then we can attack like what we're dealing with, is this related to your hot flashes and night sweats, and you don't want to look into medical stuff or treatment at this point. So maybe you have layered clothing, or, you have a little fan that you carry around with you, other things that can like improve those symptoms. And so I can't really stress the importance of trying to find a way to mitigate the stress in your life. And so I also, and I'm not very good at this myself, but like I do believe in like, I think if you can find some time to meditate 10 to 15 minutes a day, just clearing your head of all the stuff that's really bogging you down, I think it does a world of difference for my patients. And so those are some of the things that I always try to push before even talking about treatments.
Love it. Love it. Personally, what I say to my patients, just to jump on what you said about exercise, I always tell my patients the best form of exercise is the one that you enjoy doing, because if you don't enjoy doing it, you're not going to do it. And I would rather you do something.
Yeah, exactly.
But of course, the importance of weight-bearing exercise in postmenopausal women is very important. And then the other thing I want to share that I share with my patients as well is how I might trick myself into working out. I enjoy it when I'm doing it, but
Yeah,
the idea of time for it, or
Right.
getting rest to go and do it is always like a mind hurdle, right?
Right.
I always tell myself, okay, you're going to do 30 minutes. You're just going to do 30 minutes.
30 minutes,
And at 30 minutes, some days I'm just like, oh, thank God I made it through 30 minutes. And some days I'm like, you know what, I can push through another
25, 10, 15,
and so
20,
it's a win, you know what I mean?
Yeah,
So I tell my
absolutely.
patients, so just set a time limit and say you're going to do this for X amount of time, and then you've got it out of the way. The last thing before we go into break, Dr. Rahman, is with respect to specifically soy, because I know that can have or breaks down to estrogen derivatives, and so that can have some effects. How do you feel about encouraging women who are in that postmenopausal or having menopausal symptoms to ingest more soy?
Yeah, I mean, I think that there are some benefits to trying to look out for increasing the soy in your diet with the phytoestrogens, especially in terms of the hot flashes and the night sweats and everything. And then there are just some stuff you can get over the counter that basically have like a chemical similarity to estrogen, so it kind of tricks the receptors in your brain to thinking that this is like the estradiol components that the brain is used to. So like the estrogen and the black cohosh, those are the best studied, I think. And there's a couple other ones out there that I always recommend to patients. And so they're not actually, straight hormone replacement, but it is something that's more like a chemical structure that's similar to the estrogens that kind of almost tricks your brain. And some of it, I mean, a lot of us believe some of it is like a placebo effect, especially if you find it working for a few months. Great. I mean, it's working. We always say try to give it 3 months, right? So if it works for 3 months and then all of a sudden it either maybe doesn't work for you anymore, it was a total placebo effect. I mean, either way, if it's helping your symptoms, then those are very overall safe, so we don't worry about them as much,
Right. And just to piggyback onto that is to always make sure with any supplements that if you do have other medical conditions that you do run it by your doctor.
Absolutely.
Because even though it may not be straight estrogen, it may interact with some other medication.
Absolutely.
Or some other condition that you have. So as always, we're giving just general advice, but not specific medical advice. Make sure you talk to your doctor. Mm-hmm. And with that, Dr. Rahman, we're going to go to our next break. You're watching What's Up, Doc, and we'll be back after this short break.
A free 3-minute online chat can give you the personalized tips you need to start boosting your retirement savings today.
Dad, they took over my bedroom. Come on, come on. Okay, Dad. 1, 2, 3.
Are you okay?
I'm fine, dear.
Your hero needs you now, and AARP is here to help. Find the care guides you need at aarp.org/caregiving.
I am what hunger looks like in America. I am an 8-year-old girl who's not excited for the last day of school. Because this may be the last time I'll have lunch.
Till September.
I am a single father of 2 who works 3 part-time jobs, and that's still not enough to put food on the table. I was created by artificial intelligence from faces of the 1 in 8 Americans who struggle with hunger.
Feeding America, 200 food banks strong.
Assalamu alaikum and welcome back to What's Up, Doc. Today we are chatting with Dr. Sameena Rahman about all things related to menopause. Before the break, we were talking about all of the symptoms that can be managed with different treatment options for for menopause, and we started with lifestyle and supplements. Now that we've kind of discussed that pretty thoroughly, in my opinion, let's talk about medical treatment, because I'm sure a lot of people are really curious about that. For a lot of patients, sometimes that's first line before even talking about lifestyle things. So let's talk about that next.
Okay, great. Yeah, you know, obviously one of the big discussions that I always have in my office is around what's traditionally been called hormone replacement therapy, or we sometimes just call it hormone therapy. And so there's a lot of myths that still exist about hormone therapy, even in the medical community, that I wanted to address. As you know, hormone therapy includes usually estrogen, and estrogen and progesterone if you have an intact uterus. So if you have a uterus and you've never had a hysterectomy, you actually need the progesterone to protect the lining of the uterus from developing into cancer. And so many of...
Sorry to interrupt you, Dr. Rahman. I know I know you're going to get the ball rolling, but just to interrupt a little bit and give a little bit of background. The idea behind this is that as we enter menopause and beyond, we're deficient in these hormones that you mentioned. Right. The idea is to replace them so that we restore a lot of the symptoms and signs that you described in the beginning of our show. Just for a little bit of background. Okay.
Yes, absolutely. So the thought process, especially when it comes to what we call the vasomotor symptoms, which are your hot flashes and the night sweats, you know, the biggest thing and with regards to that is getting some more of that estrogen back. Now, we're actually not replacing the amount that you normally used to have by any means. In fact, most traditional hormone therapy or hormone replacement therapy, as it had been called, is really even less than what we see in birth control pills. So I think that's important to know, that it's really just enough to get the symptoms under control. So we're not actually replacing a full amount or giving you all your estrogen back or whatever the case may be. But you know, in the late 1990s and the publications that came out in the 2000s, so it's been over 20 years ago, there was a big study that, you know, some of us may remember, you know, some of us may have no idea about, but it was the Women's Health Initiative, which was a study on women in post-menopause and the impact of hormone replacement therapy. And actually it was looking more at, you know, the end goal was to see, you know, if it was protective against heart disease. But a lot of myths, a lot of information came out of that, and the study was stopped prematurely because of what was thought to be this huge rise in breast cancer and then stroke, as well as DVTs in some patients. And so the study was discontinued, and there was a lot of media press on it. And so I think that has lingered for a long time. What we know is, you know, at the age group that was studied was like a 63-year-old was average age. So it wasn't even a woman going into menopause. But I'm not going to go into details of it. But, you know, initially it was thought that these, the hormone replacement therapy, especially in the form of the oral pill of Prempro, caused an increase in breast cancer. In fact, it was reported a tremendous 24% increase, which was not the case. So when you look at the analysis afterwards, what we found was that this was not the case, that, you know, it was more like two or three out of 1,000 women, and the numbers weren't that much more than what your normal risk was at that age. So the long and short of it was that women over the last 20 years stopped using hormone therapy, and at the end of the day, we saw all these shifts in mortality rates, in heart disease, to the point where things were increasing. So we saw a negative impact of shifting out of hormone therapy. And what we've learned is, through all the studies that came after it and all the what we call post hoc analysis, where we analyze the data even more after the study is stopped, is that there's actually some great benefits to estrogen and progesterone, especially if you have a uterus. And so we're even seeing some, you know, cardiovascular benefits. We've seen benefits with cognition. Obviously, the biggest benefits are the hot flashes and the night sweats, which currently is still the only FDA indication for hormone therapy. And I have to say, and I can't emphasize this enough, it's very important that this discussion is made with you and your healthcare provider. And so it has to be an in-depth discussion if this is right for you. People with different types of medical problems, active heart disease, breast cancer, history of DVTs, you know, they're not in the same category, people that should be taking hormone therapy. And so before I even talk even further, this is something that we should always discuss with your provider. And if it's someone that you don't know is very comfortable with discussing hormones, or maybe, doesn't know all the newest data, you can always go to the website, the North American Menopause Society, and there are a number of certified menopause providers that you can find in your location that are well-versed in hormone therapy and when to use it, when to not use it, and how to use it. But the biggest thing that came out of that post-analysis is that it's really timing. Timing is everything. So if you start the hormone therapy within the first 10 years of menopause, it's very beneficial from kind of head to toe. Obviously the hot flashes improve, the night sweats improve, but we're also seeing cardiac benefits. We're also seeing benefits for women sexually. One of the big things that goes down to postmenopausally is libido because of the lack of testosterone. So some of those changes are improving with that therapy, as well as other types of medications. So estrogen and progesterone, depending on what your status is, whether or not you've had a hysterectomy or not, those are very first line in some of the treatments for the hot flashes and the night sweats in the right patient population. And I think that has to be emphasized and even the women that I have on hormone therapy, I see annually, because I want to make sure that they haven't developed heart disease, that, they're not being evaluated for potential breast cancer. So some of these things we know there's a great benefit to it, but you can't just put someone on it and just leave them be for 10 years either. You have to make sure you're really following them and make sure their health status isn't changing. As we get older, we get a lot of conditions that may be impacting us, and whether or not, that therapy can work is important to reanalyze every year. So that's one of the biggest take-home points, is that we're finding that hormone therapy is much safer than we used to think it was, and actually may have multiple benefits across the board in the right patient population and in the right time. So if it's like very close to when you entered menopause, I wouldn't put someone that was 75 that came to me and said, hey, I want hormone therapy. I wouldn't put them on estrogen and progesterone. But, someone that is really proximal to having, stopping their menstruation, definitely that's really a first line therapy for a lot of my patients. And it comes in various different forms. There's patches, there's rings, there's oral, pills, and you can kind of, fluctuate when you give the progesterone. If you've never had a hysterectomy, you need that progesterone to protect the lining of the uterus, like I said, so that you don't develop a cancer in the lining of the uterus. And so,
So it's really important, Dr. Rahman. Sorry, just because the details definitely, I don't want us to get bogged down by the details, just because, of course, as you mentioned, it's going to vary from person to person. It needs to be a personalized treatment plan with your physician based off of your background. But definitely appreciate the detail with which you explained to us that we really shouldn't be afraid of hormonal therapy in the right patient at the right time, as you mentioned. With respect to treatment, I did touch on duration, because you said that, you want to kind of start it early, but are women on this indefinitely, or are they guiding the therapy? How are you now going to guide the therapy? Because now their symptoms are masked, right? Or, they're improved. So we know that generally, if you don't treat menopause, for a lot of women in the first few years, it tends to improve anyway. So at what point are you able to decide when to take a woman off of hormonal therapy if symptoms are not there anyway?
Right. If women are, healthy and they've been on therapy for 10 years or more, and, they have no new medical conditions, and they exercise and they don't smoke, and, all the good healthy things we want for our patients. I don't rush to take any of them off. In fact, most women, you can't pry it out of their hands. Once they've been on it for long enough, they're like, you're not taking my hormones. And so I think, it's a very much a doctor-patient discussion that happens. And we look at, all their, labs, and we look at all their health conditions. But, right now, it's at least in the data and what we know medically in terms of the medical literature, there's not and most of us that treat menopause or nurse specialists you could be on it indefinitely, really. It's one of these things that in the right patient population. And especially, your symptoms will come back once you go off of it. And so some patients try to wean themselves and then they're not successful. And particularly when it comes to the bothersome symptoms around, the genital urinary syndrome and menopause with the vaginal dryness and the sexual pain and the urinary symptoms, which really impede women's quality of life. I find that, the vaginal estrogens and the topicals and the local stuff that we use to treat it, those women pretty much stay on the indefinitely as well. And there are other treatment options if we're just looking at that. So if we're just looking at sort of like improving your urinary symptoms and your vaginal health overall, improving that genital urinary syndrome and menopause, most of my patients are on vaginal estrogen, or they take vaginal, it's called Intra-Rosa, which is like a DHEA derivative that gives you a little bit of estrogen and testosterone in the vagina. We also look at, there are pills you can take that are specifically for just improving vaginal health and urinary symptoms. And then there's different forms of estrogen.
Definitely, they would need a whole consult with you, Dr. Rahman. There's, I love that, because as many as there are symptoms of menopause, there are treatments and management options. Yeah. So I think that that's wonderful for a lot of women who, as we said right at the beginning of the show, this is something that they don't talk about. Why not? There are options. There are lots and lots of options. And we even get into the non-hormonal options. We're definitely running low on time. For the woman who is for not a suitable candidate for hormone replacement therapy, there definitely are other medications that target other symptoms, including the vasomotor, the night flashes. There are SSRI, some medications used typically for depression and anxiety. So you're getting a 2-for-1 to address the irritability and the depression and anxiety we mentioned, as well as some of the symptoms. I love that. I hate that we are running low on time, but in the time that we have left, are there any non-hormone therapies that you want to highlight briefly?
Yeah, I mean, I actually, I have a number of patients who are breast cancer survivors who also suffer from some of the sexual side effects and the urinary side effects related to that lack of estrogen. And so they're not, although some of the data is, the amount of estrogen, it might be possible with the discussion with your oncologist. But there are other options out there. I always recommend vaginal moisturizers, like a hyaluronic acid-based moisturizer for my patients. Is that over the counter? Sorry. That's usually over the counter, or you can order it from, there's a website called Hyalogyn, Hyalogyn. That is, you can order it from that website. And it's a hyaluronic acid-based moisturizer used twice a week. And then obviously lubricants, for sexual activity. And then there's there's also been some benefits seen with the carbon dioxide laser. For instance, I use that in a certain subpopulation of patients that don't tolerate the estrogen. So a CO2 laser, just like lasers done on the face, you can do it in the vagina, and it really has helped women with the genital urinary syndromes. So it kind of improves your vaginal health in a variety of mechanisms. And so some patients really opt for that. And then the lubricants, like we discussed, in terms of, the vasomotor stuff we talked about, the SSRIs are probably the biggest things other than, your estrogens and that we can use. And then those lifestyle modifications, if we know what's aggravating us. I always have patients, especially the ones that either opt out of hormone therapy or are not able to take it, to kind of really do almost like a diary of their symptoms. And so we can figure out if there's any precipitating things that are impacting them. Is there a way that we can improve their lifestyle by, adding changes in their in their lifestyle to improve those symptoms?
Love it. Thank you so much, Dr. Rahman. Now, as we wrap up this episode, there's so much more that we can talk about, and I feel like this may be another episode in the making. But I want to emphasize, and I'm sure you do as well, for some of my patients who I see as a primary care physician, I'll see them for primary care stuff as well. And I'll ask them about their well woman exam. Have they had an annual well woman exam? And for my older patients, they say, well, I'm 65 and I don't need to have one anymore, right? Or I'm in my menopause, and they don't believe that it's something that's important. So another take-home message that I want to share, and I would love if you reinforce, is that the annual woman exam doesn't end. And as long as you have years ahead of you, you should continue to come in for your annual exam, even if it's your uterus, even if it's not having menstrual cycles, you should
yes.
your annual exam.
Absolutely. Absolutely. We talk about that all the time. And one thing we didn't mention is, any bleeding after menopause has to be evaluated, right? So that's something we always ask about when we do our annual visits. And sometimes a patient might not know that they have had blood in the vagina for one reason or another, and we can investigate why that might happen. And we just take an overall look at, breast health. We look at your vulvar vaginal health. I mean, some people miss conditions related to vulvar dermatologic conditions like a lichen sclerosis, which I see a lot in postmenopausal patients as well. So, I mean, there are tons of other things that might be impacting women's health, as well as, so that annual exam is still important. And like I said, if you're one of those patients that's on the therapy, hormone therapy, you better not go without a year from seeing me, because I want to make sure that nothing's happening, that we need to take you off of it or reduce it, or, is this the right method for you? So there's a lot that goes into that.
Absolutely. Thank you so much, Dr. Rahman. We covered so much. It's been a whirlwind.
I know.
I feel like every minute of it, and I hope our viewers, I'm sure our viewers will as well. So thank you again for your time and sharing your experience with us. We wish you every success in your future career.
Thank you so much. And, I'm so impressed with what you guys are doing, and I'm really support the network. So thank you for having me.
Thank you so much. We appreciate that. Thank you for joining us on another episode of What's Up, Doc. You can watch all of our shows on our website at muslimnetwork.tv. I'm your host, Dr. Al-Barwani, and I'll see you next time on another episode of What's Up, Doc.